The surgeons at the Animal Emergency Centre in Melbourne, Australia. We have a little dog named Sunny today who had an acute onset of hind limb lameness a few weeks ago. We saw it last week, the week before, and scheduled a TPLO for today. Incidental finding of some elevated liver enzymes. We did an ultrasound today which showed some diffuse changes in the liver, no evidence of any adrenal masses. Also, ultrasound was consistent with chronic pancreatitis. We contacted the owners and they were happy to proceed with the surgery, and they'll have a medical workup later on. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone next time we live stream. All right, so I'm doing a medial parapatellar approach on this little dog. And I always do an arthrotomy on my cruciates because I believe that we need to confirm the diagnosis, and also that missing occult meniscal injury can be a cause for inferior outcome with these guys. So I always open the joint to have a look. I know that that's not universal, and that some people don't open the joint to have a look, but I do, and it has served me well as a clinician. Just doing my little arthrotomy there. Cut through a little blood vessel. Okay, just hold that like that. A little bit of a bleeder up high here. Make sure that I get that patella completely luxated. The patella groove is a bit shallow. Can I get you please to just grab onto that skin there? Okay, release. Yep. All right, we'll get our stifle distractor. Get a really good look inside. So I'm just looking down at the medial meniscus, making sure that I can't displace it cranially, which I cannot. I can see it. I can see that caudal pull. Quick look at the lateral hardly ever tears. Okay, that looks great. Can I get some saline, please? And we'll get the rest of our gear open. So that, just to point out, the cruciate ligament, the remnant is just right there, but you can't really see any of it left. So there's a question about how long I would feel comfortable being in one surgery for. And the answer is just as long as it takes. I'm a pretty quick surgeon, and so it is uncommon for me to be in theater for more than a couple of hours. I'd say it's rare. But basically, you have to be in there as long as it takes to get the job done. And if it's likely to take longer than you're comfortable with, then that's, time to consider maybe whether it should be done somewhere else. Still getting a little bit of bleeding up here. Little joint mouse that I just sucked up. The other thing I'm going to do is I'm just going to have a look at the underside of the patella, because this dog does have a shallow trochlear groove, and so I just want to make sure that it doesn't have eburnation of the patella. No, that looks pretty good. Alright, so now I'm just going to close the joint capsule. Can I get some 3O PDS, please? Yeah. I'm teaching a course tomorrow and Friday in Sydney, so I have to fly out tonight. And then I have 8 hours of lecture to give on wound healing and wound reconstruction options, and then laboratory as well. So my lectures are on general wound healing and wound management substrates like non-adherent, adherent, the biologicals, as in the non-permeable. Talking about negative pressure wound therapy like VAC, talking about transposition flaps, rotation flaps, axial pattern flaps, subdermal flaps, skin grafts, all kinds of things. So that should be kind of fun. A lot of work to put the lectures together for it because I hadn't done this complete a program before. I'd done a lot of one-day seminars on wound healing. So I think we've got 16 people coming for that. Too busy I am. Go ahead and close that sartorius muscle because it is oozing a bit of blood. If I close it, I'll put some pressure on it to try to stop that from oozing. So there's a comment that I don't usually do an arthrotomy in fresh cruciate cases. The problem is that we know that cruciate disease is chronic in 90% of cases, and so even the ones that look fresh probably have a chronic component to them. And so you could have, you could still have meniscal injury even though it looks like a fresh case. So that's my approach. So I always perform an arthrotomy. There's another comment about Nocita, which I think sounds like a great product, but we can't get it in Australia. I would use it if it were available here. But it's not. Can you lift up on that for me, please? I just grab that. And then, yeah, I do have lectures in India with Wasava. Let's see here. I have about 10 hours of lectures, and I think we've got an auditorium with for 3,000 people, and it's all booked out.
Oh, wow.
So I've never done.
I can imagine you can get even busier after the lecture. Everyone taking the picture with you.
Yeah, so I've never lectured to that many people before. Not live.
Oh, really? Yeah. Well, I feel like Green Cross last year is supposed to be quite
That was about probably about 1,500, I think. All right, so now we're protecting the patellar tendon, and I'm going to use my Freer elevator to just try to remove some of that medial buttress. All right, and can I get some needles, please? 25 gauge. Hi, Mexico. I can still see that comment on my screen. So now I'm just checking where my joint space is, right there. This is a very slopey tibial plateau. It's about 35 degrees. Okay, so now I'm using a 15 mil blade.
Get some saline.
Yeah, I'll get it in just a second. So there's my cut. All right.
So do you want to get some puppy pad onto the floor? Thank you.
All right, so now I need to look up 35 degrees on a 15 mil blade. So I come over to my chart. 35 degrees, 15 mil is 8 millimeters. Check it again, 35 degrees, 15 mil is 8 millimeters. All right, so I've got my caliper here. I set it on 8 millimeters. Make my first cut. Just need a little bit of support underneath. So that's my first cut. I'll mark that with the cautery right there. Can take out these needles for the moment. And I've got my caliper here. My second cut. Didn't really mark it enough. So those are my two cuts, my two marks, which are 8 millimeters apart. Recheck, that's perfect. You have your saline. I can grab it. There you go. So now I'll just complete my cut here. Okay. All right, then we get our wire driver, pin roll. We use a 5/64 inch pin as my rotator. I think I might have gotten the popliteal artery, so this is good for you guys to see. So if you have gotten your popliteal artery, and you put in a Gelpy like that, you just get a Homan retractor. Still bleeding a little bit. Can I please get some Liostip? You don't need to replace TPLO blades. You can get them sharpened. So you just have to use a little triangular diamond file. We used to have one. Now you can just send them off to an outside place to get them sharpened. But it's a little triangular file that they just diamond file and just sharpen each of the teeth. Take that out. Okay. It was really oozing. Move that, please. Okay. So then I'm putting in my rotating pin. And grab my fixation pin. Trying to find an 054. Oh, these are 062s. There's one. Okay, so I'll just get this started. Okay, hold on to that. Does not want to rotate. Okay. Can you clean that for me, please? Yeah, go ahead and drive it. Yeah. I think it's going to miss. Come back out a little bit. Okay, stop, and then move your hand down. Okay, try again. Move your hand toward me. Come back out off the pin. Yeah, farther. Okay, and then bend toward me. Yep. Yep. Okay, stop. That's good. Okay, let's remove this. So you can see my two lines. Okay, that looks great. And I'll get my pointed reduction forcep. Okay, that looks great. Let's check the angle of the leg. That looks good. Okay, just hold on to that. Let's get some support there. Now this is definitely the 2-4 kit. That seems almost small for this dog.
Yeah, would you mind helping me to double check whether this is 2-4 kit? Should be right.
Yeah. I think that'll be all right. Okay, just watch that plate for me, please. All right, just just have another look. And then I'm just going to check to make sure that plenty of room up there. Okay. So check our length here is measuring about 3 and a bit. $14. Cortical. Go ahead and pull that distal pin out. Get it out of my way so I don't poke myself in the fingers. Also a 14. So there's a question about tightrope versus TPLO. And I feel pretty strongly that TPLO is the way to go. The issue, or my feeling is that with the primary issue of cruciate disease in dogs being the angle of the tibial plateau, it makes sense to me that the most appropriate treatment for that would be to change that angle, correct that angle so it's level. And the way to do that is with the TPLO. The reason why traditional cruciate repair techniques, extracapsular repairs, don't work in big dogs as well is because the tibial plateau angle, if you don't correct that, is going to continue to overwhelm, that's a 30, going to continue to overwhelm the whatever repair you put in there. And so I guess the benefit of a tightrope is that it's such a robust repair, but you're still always going to be fighting that tibial plateau angle. The other issue with tightrope is that I knew a surgeon who was really excited about tightropes when he was visiting us, and then He said he had done 14 of them and was really thrilled with the results because they were doing so well. And then he called us back a month later and said that 11 of the 14 had gotten infected. I mean, he's a good specialist surgeon, so I have no concerns that his technique wasn't great, and sterile technique wasn't great. And so I think, I guess there is some potential for them to get infected. Just to make sure it's straight. Yep. Let's just see. Where's my drill guide? And I'd be happy to stand corrected on that, on the tightrope, but with TPLOs having consistently a success rate of 95 to 98%, I think that's going to be pretty hard to beat. The other thing is that they do well so quickly, so they feel great really, really quickly. 24 locking. That being said, I think that technically a tightrope is probably easier for non-specialist surgeons who don't have a lot of experience with plating and that kind of thing. And if that were the case, and you didn't have access to specialists and you weren't confident during plating, then I think that probably a tightrope would be an appropriate option. Question about how often, I guess, or the first question is what rate do we see infections? And not that often, probably somewhere around 5%, I would guess. We've seen a couple of them recently, but again, we don't see a huge number of them. And then as far as the number of plates that we take out, probably a similar number, around 5%, 5-10%, something like that, of the number of plates that we have to remove after a TPLO. $20. And then TPLO versus CBLO. I've never done a CBLO. I think that with patients that have really, really high tibial plateau angles, it makes sense to me because even on this one, we can see it's a 14. I don't know if we have, yes, we have one locking 14 left. Even on this case, with 35 degrees, you can see how much of a step we have back there and how much unsupported tibial crest we have. So this might even be a case where if I was experienced in doing CBLOs that I might have done where I might have done a CBLO. So question about antibiotics. So I rarely use post-op antibiotics. That being said, with TPLOs, often we do send them home for 5 days of antibiotics, and I'm not sure that it's entirely clear that that prevents infection. that is the only case that I routinely put them on post-op antibiotics. So that's done. Let me just check my angle here. That looks great. There's no tibial thrust. So we just need a little flush and a close. So I'm just going to come over and see if there are any questions that I haven't answered. Coming back up to the top. Hello there. Hello, Mexico, Sudan, Russia, Peru, Taiwan. Mexico, India, Portland, Oregon. So there's a comment, from what I understand, both TPLO and tightrope have relatively high success rates, the main difference being that recovery tends to be faster with TPLO. I'm always really surprised at how quickly our TPLOs recover, so I guess I would agree with that. And so any special advice for a team during their first TPLO? So I know a primary care vet, GP, who's a great referring vet of ours, and he's doing TPLOs, and he has done 40 cadavers before he even thinks about, or even thought about doing his first clinical case. And I think that, I guess, demonstrates a really, substantial commitment to getting it right the first time. And there is, I guess there's a lot that can go wrong with the TPLO, and I know I make it look pretty easy because I've done, 2,500, something like that. But, when everything's going well, it's great. But when things start going wrong, that's when the experience really comes in. So do you need to do 40 cadavers before you do your first TPLO? I don't know the answer to that. And he was also a fairly proficient plater, bone plater, before he started doing TPLOs. So, that is a huge commitment. But I would definitely do, take a course and then do several cadaver dogs and hopefully scrub in with somebody else who's doing them. Our plates are made by Knight Benedict, which I think is a Mavora company. So that's a new big conglomerate in the US that has bought up a lot of the other, like VOI and Securos and a few other orthopedic implant companies. So that's who I'm lecturing for tomorrow. All right, so that's pretty much it for me. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. The other thing is that if you know of anybody else who doesn't know about the channel, then just send them a link to the channel, because it'd be really nice to get some more followers and subscribers. And so that's it for me, and I will talk to you guys soon.